All right, good afternoon, everyone. I'm Dr. Omar Bey, and we are the Physician Health Network. And basically what we are, we're a group of physicians that are here so that we can answer your medical questions. And that's all we want to do. We want to answer your questions so that you can be better healthcare consumers. It's all about your health. They understand. We want you to know as much about your health as possible. We are African American physicians, and we're going to give it to you from an African American physician's perspective. We want to break it down. We want to break it down, okay? We're focusing on health, education, and wellness. All righty, our answers are going to be plain. There's one thing that I must say is that we have several things that we're dogmatic about. And number one is that do not change any aspect of your medical care until you consult your physician. And the reason I say this is because we're all different. We're all different in each and every way, especially health. I may take a medication for my diabetes that is perfectly fine and keeps my sugar right in line. You may take the same medication and guess what, have a side effect from it. So do not change any aspect of your medical care until you consult your physicians. We're not here to get you to change your doctor. We're not here to become your doctor. This is all about education, all righty? First thing I would like to do is I would like to introduce the doctors, all right? And because I'm not sure of the order of the doctors and where they are on your screen, I'm just gonna call out the doctors' names, and I will unmute everybody so we can get going. Let me do that. All righty, unmute. Can everybody unmute themselves? How are we doing here?
Good.
All right, all right. So now I would like to introduce the doctors. Dr. Jordan Garrison, please start us off.
Hi, my name is Jordan Garrison. I am a general vascular and bariatric surgeon. Honored to be here, and please ask away.
All right, Dr. Atherley.
Hi, good afternoon, everyone. I'm an interventional cardiologist. I practice in the Essex County, mainly the Newark area. What that means actually is I take care of all aspects of heart disease, but specifically specialize in treating by invasive means, that's by passing catheters into the body, treating some forms of heart disease, such as blocked arteries. So I practice generally, and one of my favorite aspects of my practice is beyond the patients to education. And remember, the teaching faculty for the training of our cardiology fellows, fellows in training, as well as medical residents at the Newark Beth Israel Medical Center. Good to be here.
All right, Dr. Patrick Anderson. Patrick, we don't hear you.
Still don't hear you.
Patrick, we're not hearing you.
It's better.
It's better up. We're not hearing you still, Patrick.
Mute.
Yeah. Yes.
On mute.
Patrick, you have to unmute yourself.
There you go.
Yes, Chief of GYN Oncology at Newark Beth Israel
Patrick,
Medical Center.
excuse me, can you start over again?
Yes.
And let me just say, hold on. Someone has a cell phone on because we have a feedback. You cannot have a cell phone on while you're on the web. We'll have a feedback. Please cut off all cell phones. Let's get our technicals together before we go forward. All right. We still have a feedback in the back.
Can you hear me?
Probably Patrick's.
Hi, how do I sound?
Fine.
You sound good, Patrick, but we have a problem.
Hey, I think that might be you. I think you're logged on as OBHealthy and with your computer.
Down. Take your volume down, Hamlet. Okay. All right. Is it me?
Yeah, it's muted now.
Okay. Thank you very much. Thank you. I'm sorry, guys. Okay, Dr. Patrick Anderson, please.
Yes. Long introduction, honored to be here. This illustrious group of colleagues. I'm a GYN oncologist, Chief of GYN Oncology at Newark Beth Israel Medical Center. In a nutshell, I take care of women with gynecologic cancers, ovarian, cervical, vaginal, some breast, and participate in chemotherapy and planning radiotherapy.
All right, thank you. Dr. James Lee.
Hello, everyone. Dr. James Lee Jr., I'm a second-generation board-certified orthopedic surgeon. That means I take care of issues relating to bones and joints, such as shoulder, knee, and hip. I'm clinical faculty at Rutgers University and also participate in taking care of athletes in the community at East Orange campus football, as well as Bloomfield College.
Dr. Kendall Sprott.
Yeah, I'm Kenny Sprott. My background is in general pediatrics and pediatric critical care. I spent most of my career in academic pediatrics, teaching as Trevor medical students and residents.
All right, thank you. And Dr. Dwayne Fredericks.
Hey, good afternoon. I'm Dr. Dwayne Fredericks. I'm a weight management specialist. I'm a trained bariatric surgeon. I now primarily do medical management of obesity.
All righty. And Dr. Lawrence Daniels.
Hey, thank you for having me. My name is Lawrence Daniels. I'm a neurosurgeon, pediatric neurosurgeon. I have offices all up and down the state of New Jersey. I'm the medical director of pediatric neurosurgery at Jersey Shore University Medical Center. I'm glad to be here.
Excellent, excellent. Dr. James Court.
Good afternoon. My name is Dr. James Court. My specialty is internal medicine. My office is in East Orange, New Jersey. I treat adults.
All righty. And Dr. Kevin Clark.
Good afternoon. I'm a surgical oncologist. I work at the Newark Beth Israel. I treat breast cancer, colon cancer, pancreatic cancer, and I work with Dr. Anderson a lot.
All righty. And Dr. Nelson Aluya.
Yeah, hi, good afternoon, everybody. It's a pleasure to be here. I'm Nelson Aluya, originally from Nigeria, and trained as a medicine and pediatric physician. Work at Beth Israel Medical Center. I'm also an assistant professor at the New Jersey Medical, School at Rutgers University in Newark. I'm the chair of the Nigerian Physicians Association of the Americans, New Jersey chapter.
All right, thank you. And
I
I'm
call
Dr.
myself a medical advocate.
All right. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a specialty in nutrition. I'm director of nutritional support for the ICU at Beth Israel Medical Center. All righty. So after all of those introductions, what I'd like to say is that we're going to be here the second Saturday of each month. And we will come on as a group of physicians each month, the second Saturday at 1 o'clock Eastern time. So you can tell anybody and anyone can come on, and it's so easy to join us. Just go to the website, OBHealthy.com. You scroll to the bottom of the website and you hit Zoom webinar and follow the instructions, and it opens up and you will be in the webinar to ask your medical questions. It's so easy. So that's one thing. Note that next month, and I meant to tell all the physicians, next month, we're going to take a break in August. So August, we will not be on, but September 12th, we will be here. And because vacation happens and we're trying to give everyone a chance to, just to cool back just a little bit before we start the year off. And September will be our third webinar, and we're just going to continue each month, second Saturday, 1 o'clock. Be here with us. All righty. So let's get started with some of the questions. I've already gotten questions as far as COVID is concerned. So let me read the first one. How do we stay productive and motivated during the time of quarantine? And quarantine, I understand that quarantine is very difficult for most of us, especially for our children and our seniors. So let's grab this topic, because I know that from what I hear, depression is increased, as far as interrelations, as far as families are concerned, it's becoming more difficult. Can we start this off as our first question? Because I think we're going to get a lot of questions as far as COVID is concerned. Who would like to chime in on this one, since it's our first question? Dr. Sprott, can you start off with us?
Well, I can start off by saying the first thing is to try and stay healthy and not get infected with COVID. And part of the way that you do that is you stick with sort of the CDC guidelines, which involves social distancing, which means staying at least 6 feet away from folks and wearing masks. And in general, there are two types of masks that people commonly will use. One is called an N95 or K95, and they are masks that are designed to prevent small particles from getting in. That's why the 95% of particles can't get in. And that's designed primarily for use in health workers, or when you think that you might be exposed to someone that actually has it. In addition to that, you know, in the hospital, people have shills and gowns and things like that. But the more commonly used masks are the sort of surgical masks. Most of them have the elastic loops around the side, and they're used to prevent you from spreading it. A number of people might have COVID and are asymptomatic. They might not yet have a cough, and later they might develop a cough. But if they do, then if you're coughing through a mask, then the particles, the virus, very little of it is able to get out and around. And therefore, it's important if you're looking to try and protect others from getting the infection, when you don't know that you have it, to wear that kind of a mask. And it's very, very important. You know, when you looked at some of the things that are happening in New Jersey, which where we're from, we went through a spike of cases, but we were able to have that curve not only flatten, but go down. And so we're in pretty good shape. The number of, you know, when they talk about capacity for intensive care as well as respirators, we're down to only 3% utilization. In some of the places where it's raging, you know, they're down to single digits in terms of available ventilators and CCU beds, and they're going through what we went through earlier. So it's very, very important for you to understand that a lot of folks that are spreading the infection don't know that they have it. And so the goal is until possibly a vaccine is developed later in the year, is to social distance yourself, not get involved in lots of folks that are around. And you know, in the initial phase, it's not in groups of 10 and then social distance. So the best thing to do is to stay safe and keep yourself safe, and to make sure that you don't expose yourself or expose others to the risk of getting it if you might happen to have it and you don't know it.
Right. Let me chime in. We have a lot of questions. Dr. Atherley, I know that we have questions for cardiology. There was one question that says, does COVID cause heart attacks?
Well, that's a very good question. COVID does affect the heart in multiplicity of ways. But if you ask specifically about heart attacks, I need to explain what a heart attack is. A heart attack essentially occurs when the heart muscle, which as you all know is the strongest and most powerful muscle that we have in our body, the heart is working. When the heart muscle itself is deprived of its blood supply, then it can cause a portion of the heart muscle to become damaged, and after a period of time, irreversibly damaged. That is a heart attack. Now, the usual heart attack occurs when the arteries to the heart, which supply the heart with its own blood supply. You see, the heart pumps blood everywhere else, but it has to get its own blood supply so that it can function effectively. So when the heart's arteries, the little arteries that run on the surface of the heart, I think I have a model here in my office. Let's see. If you can see this, these little red streaks are the little arteries that run on the surface of the heart. When these become blocked from the inside, usually by fatty deposits, they diminish the amount of blood flow that the heart is receiving. And this may accelerate as they rupture and form clots and suddenly block those little arteries, so that then a major portion of the heart, or sometimes a minor portion, may be deprived of blood and irreversible damage occurs. This normally occurs as a consequence of fatty deposits, cholesterol buildup, etc. Now, in the case of COVID, while that has been accelerated in some circumstances, we've observed COVID causing an acceleration of that process. There are other mechanisms by which COVID causes heart attacks. COVID itself tends to increase the ability to form thrombus or clot in many of the arteries and veins in the heart. And by forming clots in the heart, even in the absence of otherwise diseased arteries, those clots can give rise to heart attacks. So those are two of the mechanisms that we commonly see, either acceleration of the normal or increased clotting. There are a few others as well, damage to the lining of the arteries, etc. But I will say that COVID does affect the heart in a multiplicity of ways. If you look at patients who died of COVID,
Oh my
about
God.
40% of these
Oh my God.
patients,
Oh my God. Oh my God.
about 40% of these patients will have COVID of the heart as well. Maybe later on, I'll let some others answer, but maybe later on I could mention some of the other manifestations, some of which occur fairly commonly too. Some of the other manifestations of COVID heart disease as opposed to COVID heart attacks. But COVID heart attacks are, yes, a dreaded complication of COVID, and we saw increase in frequency of these. I suppose while I'm on it, let me just mention one thing. It's a kind of pseudo heart attack. There's a disease called stress cardiomyopathy, where stress does cause what looks like a heart attack. And this became popular a few years ago as the broken heart syndrome. You all heard of that, where people exposed to stress for a variety of reasons suddenly had what looked like heart attacks. When we studied these patients and did the usual tests that we perform, we found no evidence of blocked arteries. We found that the heart appeared to function like a heart with a heart attack, but after a few weeks recovered significantly in its total function. Well, there have been a few studies which show that in several patients who came to the hospital with these infarctions or apparent heart attacks, that A, COVID was present, or in B, some in whom there was no COVID present, that just a mere concern and stress about the COVID situation increased the incidence of these pseudo heart attacks. So these are some of the ways in which COVID may cause heart attacks, real heart attacks, or pseudo heart attacks.
Right. Okay. Thank you, Dr. Atherley. You know, we're getting quite a few questions coming in, and I'm going to try to read these and cut them down. They're a little lengthy, so bear with me. Dr. Lee, maybe I'm sorry.
Let me, if I can add one thing to the question that
Oh,
we're
go
answering.
ahead. Yes.
The question was about, you know, how to stay productive and motivated during the quarantine times.
Right.
And I want to make one point, and it's a segue to Dr. Atherley, and it's that mental health is important. In our community, we oftentimes neglect mental health.
Right.
But there's a tremendous amount of stress that everyone is experiencing that's affecting all aspects of health. And if you find yourself feeling not motivated and not motivated enough to get up and do the things that you normally do, it might be the accumulation of this stress, whether it's from COVID, whether it's from civil unrest, whether it's from, you know, a terrible administration, whatever it might be, you know, you might be suffering from mental health problems. And you should speak to your primary care physician about this to get started on maybe, you know, developing a treatment plan for it. Oftentimes we neglect this. And right now, you know, we're used to having to deal with stress, but it's getting overwhelming. And I'm seeing physicians experience this in their offices in all different specialties. So another thing that can keep you motivated is to have this discussion with your physician and maybe, you know, seek some treatment for some of this additional stress and anxiety that almost all of us are experiencing nowadays.
Right.
Omar,
Hold on, Dr. Garrison, go ahead.
Okay, I think Dr. Sprott and Dr. Daniels eloquently talked about two aspects of our well-being, our health. But there's a third aspect that we need to address as well, and that's our spiritual well-being. Right. You know, we have to admit there are limitations to what we can do and can't do. But there are fellowships that you can go online. There's prayer services that you can attend. There is the conversation you can have with your family and admit that you are under stress, that you are not feeling well. We can go out, we can distance each other. We can get with a couple or a friend that has been socially distanced and doing those things. As my shirt says, you know, spiritual fellowship is a part of our mental health. And that's probably one of the things that we're trying to address here in this meeting is not only our medical health, but our spiritual as well as our mental health as well.
Yeah. Who is the second person?
Court.
Dr. Court?
Yes.
Yes, please.
Okay. One of the things that I've noticed in my patients who have been to see me recently in terms of coronavirus disease is a tremendous weight gain. When I ask the patients, well, why are you gaining weight? The usual answer is COVID. One of the things that they do while they are not working is they eat more. And I think we really should emphasize that although you may eat more, you should not forget what you should do in terms of maintaining your weight, namely diet and exercise. And it's really been a problem because most of my patients that I've seen recently, they have gained weight.
And the reason can
You know-
be because when you're under stress, that increases, it's inflammatory. And that inflammation actually affects the basal ganglia and it makes one get more hungrier. So it's the actual reason why that actually happens from being under stress.
Right, right. You know, the thing of it is, we've gotten questions as far as weight is concerned. And they are talking about the fact that they are at home more and they're gaining weight. What can they actually do about that? And maybe we can give some suggestions, maybe more fruits, more vegetables, decreasing your carbs, decreasing, and snacking other than ice cream and potato chips. Try snacking on vegetables, or I know it's not fashionable, it's not cool, but carrots or vegetables or something like that. That's a low calorie snack as opposed to potato chips. And those are things. So those are some of the things that we have to look at as well. All right. Is there any more on that topic? Because we're going to move along here. I'm going to try to, there's one topic for Dr. Lee. All right. I enjoy lifting weights for the aesthetic as well as perceived health benefits. But I've met several people, a number of older gentlemen who claim that the muscle, joint, and immobility issues due to weightlifting in their younger years, it's a problem for them now. Are the rewards of weightlifting greater than the risk? Dr. Lee, can you help us out?
Yeah, I think that's a really good question. I think when people who are into fitness, weight training, I think those individuals really have to look at balance. What are your goals? If it's aesthetic and you're in a competition, that's one thing. If you're doing it for health, that's another. The natural history of many of us as we age, our joints, especially the ones that bear weight, such as your knees, hips, and a little bit of your shoulders, they will slowly degenerate just from wear and tear, right? During that time, you can still build muscle. But if the muscles are so strong and the joints aren't as strong and they're degenerating, then yes, you can have this imbalance. So what I would say is it's important to be balanced. Don't overtrain. Look at it as a way of maintaining fitness, but balance it. So if you're into weight training, one idea that you could propose, or I propose, is work on different different muscle groups, alternate muscle groups, upper body, lower body, core, back. And if you're balanced, you can still add muscle, you can still have tone well into your golden years. That's perfectly fine. The issue is, have you or have these other people developed arthritis or wear and tear that has affected their ability to train? And that's where balance comes in, and that's where awareness of your body and your joints. What I generally counsel athletes, people who train or are in sports, are during the activity, the sporting activity, the weight training, if you're feeling a lot of pain, not the muscle burn, but joint pain, something is wrong. Either your technique or what you're doing, or it's too much weight. If you're feeling soreness afterwards, that's generally okay. But what I would advise is you shouldn't be in a tremendous amount of pain in what you're doing, and clearly define your goals and reevaluate as you go.
All right, excellent, excellent.
Can I weigh in on that?
Yeah, definitely, Jordan. Yes.
Let's clear up the fact that weight loss, because a lot of these questions have to deal with weight loss and weight gain. That weight loss, 90% of it is nutrition and 10% is exercise. In order to lose a half a pound, you have to run 20 miles a week and you'll lose a half a pound. So that means if you think that you're going to exercise a couple of days a week and you're going to lose this tremendous amount of weight, it's not going to happen. Where it comes in is what you eat. And you mentioned about substitution of fruits and vegetables versus carbohydrates and things like that. The basic formula is the more you take in, the more you gain. The less you take in, the more you will lose. So that's where the nutrition aspect of it comes. Exercise will augment that. Exercise will make whatever you do with your eating more efficient. But exercise is not the number one thing that is going to lose weight unless you're trying to become a world-class athlete. But I think for our patients, the key is nutritional guidance. And we have Dr. Fredericks, Dr. Bay, who can talk more to the nutrition than I can.
You know, the thing of it is, just to chime in, you think of it in calories, because a lot of times we don't like to count calories, but if you just look at a package and look at what you're eating and look at a portion size, if you really understand what a pound of weight loss is, if we decrease for our total calories for one day, if we decrease that by 500 calories per day, that's 3,500 calories per week. That is 1 pound loss just by decreasing those calories. So understand, just by cutting back, maybe not eating the ice cream at night, or maybe adding in that exercise as well, but not eating that full bowl. Maybe you have just a couple spoonsful instead of the full bowl. But you understand, just by cutting those calories back, you will lose weight, because it all comes down to metabolic rate. If you burn the calories, if you take in more calories than you burn, you're gonna gain weight. If you take in less calories than you burn over a 24-hour period, you're going to lose weight. It's very simple. All right, Dr. Fredericks, do you have anything to add to that?
I totally agree with you. It's all about the caloric density. If you're eating something that's highly caloric and it's a small amount, and you're trying to fill that stomach up, you're going to get a lot of calories. Those highly caloric foods tend to be smaller. So you want to eat things that are not as calorically dense, that are something like a broccoli that's not calorically dense, but it's nutritionally dense. And those things, you eat more of those, and those things to fill your stomach up and control your hunger. Hunger is based upon how the stomach is stretching. So you can control it.
If I might say something, Omar, I think, it's a combination and a balance of activity. It's consumption and activity. And we know where intake with respect to nutritionally dense food, as in micronutrients, calorically dense food, as in the amount of what you eat and the type of food you eat, in conjunction with exercise. I mean, Dr. Lee, we have this conversation all the time. You exercise, you build muscle mass. You build muscle mass, you improve your oxygen consumption. It's like a well-tuned machine. So now you improve oxygen consumption, you utilize fuel more efficiently. So it's less stress on the digestive system and improving the consumption of that which you take. And therein lies the basic concept of the well-balanced activity, diet and exercise.
Thank you.
I'd like just a quick comment
Go ahead, Dr. Sprott.
The question that was asked. And I think, to a certain extent, people need to have goals and what they're trying to achieve. And so a lot of folks that lift weights are looking to build muscle. And there are a couple of ways that you can do that. And some of it has to do with how much stress you want to put on your body at certain points. And so one of the things that has evolved over time is sort of how to go about building muscle and not harming yourself. And so one of the things that it's been found out is that you can build muscle by keeping that muscle under tension. And you can keep that muscle under tension for longer periods of time by doing slow repetitions. That means you might count to 7 going in one direction. Let's say you're doing something for your biceps. You go 7 seconds going down, and then slowly 7 seconds going up. And that muscle's under tension. No jerking motion, and you just do that. And that builds muscle faster, and you don't cause any kind of harm or injury in general, because you're not doing any herky-jerky. Another aspect that's come into play is, in terms of sort of burning calories or being more efficient with it, is something called high-intensity interval training, where you do a lot of aerobics sort of fairly quickly, maybe for 30 seconds, and then you slow down for about 1.5 minutes, and you start to repeat that. That's sort of, and you can limit the amount of time that you spend doing the exercise to about 20 minutes and maybe 3 times a week. And that's as good as doing a lot of aerobics for a longer period of time. So part of the goal, especially as you get older, is to be a little more efficient and smarter about what you do and how you do it. If you're going to build muscle, the way that you build muscle is you start to break down some of the muscle fibers by putting more work on the muscle. So if you're looking at building more muscles in your arms, you have to increase the amount of weights that you're using in order to build. If you continue to do the same amount, you'll get to a certain point and you won't get any bigger. A lot of folks don't necessarily want to be big, you know, they call them muscle bound. So you need to look at where you want to be. And then once you get there, you can maintain it. You don't have to go any further. And those muscles, you know, you'll be able to do it for a longer period of time. You might want to say, well, I'll do it for a longer period of time, but you don't have to go any further than that. So I think that part of the issue is sort of looking at this slow repetitions if you're using weights, and this high intensity interval training, which means that you can exercise a lot less time and maximize the efficiency with it.
All right, thanks, Doc. Let's go on. Excellent. Let's go on to the next question, Dr. Aluya. This is a question that just came in. My 1-year-old has croup. We took the baby to the doctor, and the doctor gave us medication that looked like cough medicine with steroids in it. The medicine didn't work. What should we do now?
Well, I mean, croup, like most of the viruses that happen, that come, you know, at this time, are usually seasonal. And one of the biggest culprits is the virus called respiratory syncytial virus. And that, when, you know, it's also gotten by droplets, and kids particularly are more at risk to having croup, and it affects the whole airways from the nose down to the lungs, and then they hypersecrete and sometimes go into what they call bronchospasm, almost like what you get with patients who have asthma. So it's hyperinflammation, which is number one, hypersecretion, and then bronchoconstriction, which is the third component. So a lot of the times, those kids, from mild, moderate, and severe cases, in mild cases, just the regular, you know, runny nose and all that. Moderate, they get the runny nose, the cough, and everything else. And then the third component is the bronchoconstriction, when, you know, they get the wheezing and the difficulty breathing. Now, I don't know what state that child is, but usually when you see a pediatrician, you know, the management is usually symptomatic, and it often resolves itself from mild to moderate. But moderate to severe, then they may be admitted in the hospital, where they keep them in a steam room, just to keep them, you know, the airways open, and they may need bronchodilators. And of course, steroids to open up, you know, to reduce the vasoconstriction, constriction, and the steroids to reduce the inflammation that happens. So it depends on what extent of stage of the disease the child is. Apparently, if it's something that, you know, they just gave cough medicine and you went back home, most likely it's a mild and moderate. At that case, it's self-limiting. It will resolve, and the child would, you know, heal completely with no sequelae. Pertaining to the point that the child has no background, you know, chronic medical issues.
Okay. All right. Thank you. You know, what we're going to do is also, I know we're physicians, and just let's try to be mindful of our medical jargon and try to break it down as best we can, to make it as plain as we can, because we don't want to be over the audience's head. I really want everybody to understand what we're talking about from a Black perspective, you know, and we got to give our perspective as far as this is concerned. Dr. Clark, try this one here. This question just came through. Why and how does cancer move around the body? Number one. All righty. What does cancer stages mean? Okay. Can you help me out with those two?
Sure. All right. So I think first we should start off by describing what cancer is. And the best way to describe it, it's an abnormal growth. So it's a tissue that normally occurs in the body, but for one reason or another, it's dysregulated, which means it is not, it's able to grow and expand, and beyond expanding, it also is able to go to other parts of the body, which is called spreading or metastasis. The hallmark of a cancer really is its ability to not only grow and spread, but to go from one spot to distant sites. And the reason why it's able to do that is because it acquires different abilities and different characteristics. So for instance, if you have a colon cancer, it grows primarily, it starts off in the colon, and then as it gets those ability, it now has the ability to spread to the lungs or to the liver or to other parts of the body. And that's what
How
makes
does
it
how does
dangerous,
it get
because
there
it has
though?
the
How does
ability to
it
spread.
get, Dr. Clark? How does it get there? How does it
So
get from the colon to the lung or to the liver?
So there are different routes. It can typically get there through the bloodstream.
Yeah.
It could get there from direct extension. So if it's a tumor that's in the abdomen, it can get there from just the fact that it's physically close to other structures. But for the
So it
most
actually
part, it's
grows
usually,
into the other structure.
so other structures meaning other organs that are in the abdomen. So
Right.
usually though, it's through the bloodstream or through the lymphatics that the tumor goes from one site to a distant site.
Omar, in pediatrics, a lot of the cancers are blood-borne, like leukemia. Most folks have heard of leukemia. And
Right.
so you're not talking about a solid tumor that's sort of coming from an organ like the liver or the kidney or some other structure. It
Right.
spreads and it flows through the bloodstream. And it can, and part of that can mean that it can also spread into the fluid that surrounds the brain, called the cerebral spinal fluid. And so for those kind of tumors, they start out usually in the bone marrow, which is where these cells are made, and then they travel throughout the bloodstream. A lot of the more solid tumors spread via, as Dr. Clark said, through lymphatics. And so part of what happens is that, you know, there's fluid that surrounds all of the cells. It actually comes from the blood, but it's clear fluid that surrounds the cells. And that fluid that's made is sort of circulates and then is returned back to the bloodstream. And so those lymph channels are the way that fluid that is created to surround the cells return back to the bloodstream.
Right.
And they're a series of lymph nodes. So when people might have a breast cancer or something, they'll do a surgery and then they'll check the local lymph nodes, because those cells that were cancer cells in the breast will go to lymph nodes and they may find them there. So you'll see, you know, and they sometimes, you know, take several samples that sample the nodes to see whether or not there are any cancer cells there. And so when they talk about staging, they talk about whether or not the cancer is subtle, and we're talking about solid tumors now, whether or not that it's right at that site and it's nowhere else. And when they may perform surgery, they say they got it all. And then when they say they got it all, it's usually because they've looked at the nodes around and they haven't found anything. And then they look to see whether or not they might have something in the nodes. Well, if it's not, if they didn't get it all and they said that it nodes, then that's a different stage than the first stage. And then it's more distant spread to other organs. Those are the various gradations in terms of the staging. So when you talk about the various staging, the larger the number is, then the more distance the cancer is spread from that original site.
Right, right. Okay, thank you. Thank you. Excellent, excellent. Dr. Daniels, there's a question here that came in for you. I'm going to have brain surgery, all right, and for a brain tumor. What's the chance that I will get all my function back? Number one, they have several points to this question, and hopefully we can at least grab some of the answer. How can I best prepare for the surgery? And what can I do after the surgery to help myself heal?
Okay. So, good questions. What I will say is this, if you're getting ready for brain surgery and these are still questions that you have outstanding, you need to really sit down and have a long conversation with your surgeon. Because in order for you to undergo this surgery and understand the risk and the benefit of the surgery, you have to know what the risks are. So if you have any disease process that's in and around the brain or the spinal cord, and a surgeon has to remove it, there's a risk of injuring the surrounding normal brain. I say this a lot to patients. It's not difficult to take out a brain tumor. The difficulty is taking out the brain tumor and leaving the rest of the brain alone. And what's going to decide what type of injuries you are at risk at is the location of your tumor. Is your tumor located in something we call an eloquent area? Is it a part of the brain where there's a known function? Is your tumor located in your parietal lobe on the left side, which for most people is where the speech function is located? It could also be in the frontal area where the motor function is located. Is it in your temporal lobes where the memory is located? So depending on the location of the tumor and its proximity to these eloquent areas, it will indicate what functions may be at risk by going in and trying to take out the tumor. What you can do to prepare for the surgery is, and nutrition is important. So the same comments that we made about nutrition in terms of losing weight and staying healthy are the same comments that apply anytime you're going to undergo a surgery, right? Put things in your body that are going to give your body an opportunity to have the energy and the proteins required to heal from the surgery. Same thing after the surgery. You are going to get a list of specific instructions from your physician that are going to let you know what things they want you to do and not to do, how they want you to take care of the wound, what activities to engage in, and what to do if, say, for instance, you get something leaking from the wound, which could be a sign of infection, who to call. So, I come from very humble beginnings. I see myself as a doctor of the people. Something that I am really passionate about is justice in medicine and autonomy in medicine, which means that we as doctors and nurses and anesthesiologists and scrub techs, we all CEOs of hospitals, we all work for you. But in order for this to work, we have to teach you about specifically what's going on in your body so that you can then direct us to what you want done and how you want it done within reason. So that's the general answer. I wish I could get more specific, but what you really need to do is you really need to call your surgeon and have this conversation with them and make sure they take, all the time to give you that information. Because these are the important things for you to decide, one, whether that's a surgeon you want to go with, and two, whether you want the surgery to be done or not. So I believe these things, you have to be an expert at these things because you making this decision is one of the most important decisions you're going to make in your life.
I
I
agree.
just want to
I agree.
emphasize.
Can I ask a question?
Hold on, Dr. Sprott. Let Dr. Anderson, go ahead. I'm sorry.
Yeah, this is more for a question for Dr. Daniels. With respect to these neurologic surgeries and the anticipation of potential deficits, do we counsel patient with respect to potential therapies afterwards, physical therapy, occupational therapy, speech therapy, and those kind of things, and how effective they can be in the post-operative phase?
Absolutely. We all know this, right? We have some doctors who are very busy. They have very busy, successful practices, and they just don't really have the time. And so, they'll go over the general risk that we all do: risk of infection, risk of bleeding, risk of stroke, heart attack, death. You're going to hear these things. And essentially what doctors are doing is they're covering the range of risk from the most mundane to the most dangerous. And so in the doctor's mind, when you tell a patient there's a risk of getting a stroke or dying from this surgery, you feel like you've covered all the risk. But if you want to get into specifically what is my recovery going to look like, what type of deficit I might have, and then whether I would recover from that deficit or not, and what is it going to require of me to recover, you have to get into the minutia. And in order for that to happen, you have to spend time with your doctor. And it should be an exchange. It shouldn't be your doctor just telling you what they think is appropriate. It should be you asking questions and probing and getting a thorough understanding of what you're getting ready to embark in.
Okay, excellent. We're getting excellent. We're getting a lot of questions on surgery today. There's another one. Dr. Anderson, can you help us out with this one? My doctor wants to do surgery for my fibroid. Okay, I don't want to have my uterus taken out. Are there other options?
Yes, let's start by describing what a fibroid is. A fibroid is a tumor of the smooth muscle. And there's smooth muscle throughout the body. There are smooth muscles in the blood vessels, they're in the heart, they're in the uterus. But the fibroids that many women talk about is typically that which occurs in the uterus or the womb. And there are several types. These types, they can be inside the uterus and cause extensive pain, heavy menstrual cycle. They're the ones that's just in the wall of the uterus, and they can cause the uterus to grow to enormous sizes and cause impact on other surrounding organs, cause pain, compression of the urinary system, pressure sensation in the bladder, and then, frequent bowel movements. So the management of these fibroids should be with a goal in mind. And that goal in mind often refers to the symptom that the patient is having, and commonly in young women, fertility expectations. Now, surgery is not the be-all that end-all. And in general, there are several aspects of management. There's the medical aspects, and there's the surgical aspects. And the decision as to which aspect to employ depends on the symptoms and the severity of the symptoms. Now, surgery is not the only thing. Now, if we go the medical route, the medical routes are often temporary, and it's based on the fact that many of these fibroids are hormonally active tumors, and the hormone that's usually in question is estrogen. Now, that requires blocking the estrogen source or an estrogen receptor on the fibroid. Typically, this comes with many different symptoms. And as a result of that, these medical managements are typically temporary. Some of the side effects of medical management, they range from, nausea, vomiting, hair loss, bone loss, and it depends on the duration of the management. And often what happens is, after cessation of these treatments, you get what we call rebound growth. The fibroids often grow back larger than they were. Then there is surgery. Surgery is essentially two types. There's the myomectomy, or removal of the fibroids, but leaving the uterus behind. And there are several ways to do that. There is, laparoscopic, there is open, there is transvaginal, there is hysteroscopic resection of these fibroids. And again, it depends on the size, the symptoms, the location, and as important, the experience of the operator. And then the most definitive surgery is the one that removes the uterus with the fibroids. And in doing so, that certainly impacts fertility, and it doesn't necessarily impact the hormonal source. So that's usually reserved for women who have completed childbearing and who has had several failed attempts at other treatment modalities. And then there's the one area that's kind of in between. And when you think about how these tumors grow, they either grow because they're stimulated, as in the hormonal aspect that I mentioned, or nutritional aspects, as it relates to blood supply and the source of the blood supply. And one of the intermediate way to manage this is what we call uterine artery embolization. And that's performed by an interventional radiologist. And essentially what's done is they do an angiogram, which outlines the blood supply to the fibroids. And essentially they insert pellets by going through the groin and identify the specific vessel that feeds these fibroids. Mm-hmm. And they put these pellets in and obstruct the blood supply. And in doing so, it'll cause the fibroid to shrink. So surgery is not the only treatment. There's several treatments, and one needs to discuss this with your doctor, and an important part of the discussion ought to be the patient's goal.
Okay. All right. Thank you, Doc. Well covered too. I want Dr. Court. This is a question that came in for blood pressure. My blood pressure is usually 170 to 180 on the top number and 90 to 105 on the bottom number. My doctor can't seem to get it under control. I'm worried about it because my family has a history of stroke. Is it possible for me to have a stroke as well?
Yes, it's possible, but one cannot really predict at what level of your blood pressure that a stroke will occur. You just cannot predict it.
Right, right. What about blood? Talk a little bit about blood pressure, because it's so important as far as, us as, people of African descent. I mean, blood pressure is an issue. Can you talk about what the top number means, what the bottom number means, where it should be, where our doctor should try to keep those numbers?
Well, okay. The top number is usually called a systolic blood pressure, which is the pressure that's in the artery as the heart starts to pump the blood. And the bottom number is called a diastolic And that's the pressure that you get when the heart is relaxed and blood is flowing into the heart itself. The normal blood pressure is currently about 120 over 80. And our aim is to get the blood pressure as low as possible. I'm not sure why your doctor cannot control your blood pressure, because there are many, many different blood pressure medications that can be used. In addition, your doctor would have to look at you and see what other things might be contributing to your blood pressure not being controlled. For example, there are many things that can that can contribute towards blood pressure being elevated. Common medications that people use for colds, common medications that people use for pain, like for arthritis, called non-steroidal anti-inflammatories. What is your weight? Is he using medications of different classes, and so on and so forth? So there are many, many different aspects of why your blood pressure is not being controlled.
Let me add a little bit more about the blood pressure, though, because there are a few important points that I may emphasize that James mentioned. First of all, the numbers have been changed, and we keep changing those numbers based upon newer research levels. And what is now considered the normal level, the average level, is a little lower than before, and our aim is a little bit lower than before. So one question the patient may have been worrying about is, what is the aim in treating the patient? And 170 is certainly too high, and the 100, more than 100, is certainly high. So we determine different phases of high blood pressure: normal, elevated, then blood pressure elevation, stage 1, stage 2, and then hypertensive crisis. All of these based upon the levels. That patient is certainly at a hypertensive crisis level. Our aim is to get the patient down to what is called the stage 1 or so, where the blood pressure is 130 to 139 systolic and 80 to 90 diastolic. I must add, and I'm sure that James has the same problem, that to get patients' blood pressures down to these levels, we oftentimes have to give them multiple medications. Many of the patients are on 3 blood pressure medications, and the side effects, of course, are increased. So the question for this that this patient may be concerned about is, one, how much medication can I get? How much am I getting now, and how much can I get? And that's a question to be discussed with their physician. But certainly it is not uncommon with patients who have severe high blood pressure to require 3 different medications of 3 different classes so they can act concomitantly.
Right, thank you.
The target we mentioned, but the other point this patient made about stroke, again, as a cardiologist, I want to emphasize, it's not only strokes. We have to recognize that the danger from hypertension, the silent killer, one of them is strokes, but it can affect the blood vessels and cause consequences in many other parts of the body: the eyes, the kidneys, and of course, the heart. So there are multiple complications and circumstances that can occur and can be related back to high, uncontrolled blood pressure. So I would emphasize this patient, yes, you must have that blood pressure controlled in order to recognize the absence of the long-term side effects from high blood pressure, which can occur.
Right, thank you.
Yeah, if I may add that to a little bit, it's important, especially having to sit down primarily with your primary care physician and discuss the reasons why your pressure is not being controlled. One, are you compliant with your medication? Are you really taking the medication as they had asked you to take those medications? That's one. Two, are there other confounding issues that are there that are affecting the reason why your pressure is not being controlled? One, are you still taking a lot of salt like you used to? Are you living a very sedentary life? Are you gaining more weight than usual? Are there other issues with regards to problems in the kidneys? Or are there other medications that you're as well also taking, like steroids, or even over-the-counter medications like Dr. talked about, that also causing these medications not to work properly? And again, what type of meds are you taking? Are they really good for you? One of the things we'll begin to really think about again, and this is going back to genetics and everything else, we'll begin to understand, epigenetics more, and how, the environment, the food, and everything else you eat, and your genetic makeup determine the kind of medications that works best for you. Just like Dr. Attali said, not just the eyes, the brain, the kidneys, but also the heart. And often enough, we tend to forget, and I regress back to why often enough in our community, we have a lot of high blood pressure. And sometimes they got so set, I'll use that word, and the debilitating effect is so hard on us, because often enough we forget that children do have high blood pressure. As a matter of fact, the studies that were done, with the parameters for pediatrics high blood pressure was actually done in 2004, but this was revised again in 2017, where they realized that, listen, we know that our kids are getting bigger and stronger, and of course more obese. So the risk of hypertension is even much more with these kids. So when they use the parameters for kids right now, it's actually not based on age, weight, height, or race, or even sex. For the 2017 parameters, it's blood pressure in children, in adolescents, is 130 and above systolic, and 80 and above diastolic. That's the cutoff. As compared to the 2004 recommendation, which was based on height, weight, sex, and race. Now, when they do these parameters, they actually did, it's called a Brugada study. They ran over 3,900 kids over a course of 36 years, and found out that 19% of children are having high blood pressure more now than we used to think back in the days. Now, one of the confounding things that they found was, look, sustained high blood pressure over a course of time really does affect the heart. The muscles get thicker, and the function of the heart really depresses. So we need to pay attention to that. And for parents who are out there, look, listen, talk to your pediatrician as well. Find out if your kids have high blood pressure. The question is, when do you begin to ask what's your blood pressure? When do you begin to ask to check the blood pressure for a child? Usually recommendation says 13 to 17 years of age. That's the new recommendation. However, I, as a pediatrician, have always said this. If I have a child who's 10 years old and has a weight proportion that's over 80% of what's expected for his age at age 10, I begin to screen them for high blood pressure and also cholesterol.
One other thing, the doctor should also consider the surgically correctable causes of high blood pressure, namely coarctation of the aorta and renal artery stenosis, and if there's also a tumor in the adrenal glands.
Right.
Towards the patient's blood pressure being so high.
All righty. All right. We have quite a few questions coming in. There's one question. I was playing sports and hit my leg and now that I have continuous swelling and the veins seem to be a problem. Dr. Garrison, can you help out something as far as veins are concerned and legs?
Sure. Well, vein disease is a hereditary problem. Simply put, the arteries bring blood into the leg, the veins remove the blood, and it should go out in a stepwise fashion, up, across, and out. When you have vein disease, the veins dilate, and then you have blood going backwards, which can give rise to swelling, pain, fatigue, heaviness, and varicose veins. At night, you can get restless pain. The specific treatment or diagnosis of this is to do an ultrasound of the legs, where not only do you look at the deep system where the clots form that go to the heart and can be dangerous, but look at the superficial system, which usually is the culprit for this entity. It seems that this person who's asking the question had trauma induced to its leg. So there may be some disruption of the vein, but there may be some other orthopedic causes that causes the swelling in the extremity. So those things need to be looked at. But the simple solution would be to come into an office, have an ultrasound performed. If the veins are dilated, then there's a specific treatment. The goal of the treatment is to close down all the bad veins or the dilated incompetent veins so that the blood would reroute into the competent veins. Those are office procedures. They require coming into the office visit. You can drive to the office, drive home, resume your normal daily activities. In the past, we used to open up the legs surgically in the operating room, which was very traumatic, very painful, and required a long period of recovery. The treatments now are so far advanced from that, again, it's an in-office procedure. It's in and out, no more than 45 to 50 minutes, and you can resume your normal daily activities within 24 hours.
Excellent.
I'd like to come in on that if you wouldn't mind.
Dr. Lee, go ahead.
So, if we have an athlete that we're going to evaluate, or, weekend warrior, whatever, somebody who's hurt on the field, or, some weekend sport, things we look at are pain, swelling, range of motion. That means the ability to move that arm, leg, whatever it is. We mentioned swelling and strength. And so we immediately look at, that extremity, and we test physically for any fracture, or if there's any ligament. A ligament is a structure that attaches a bone to another bone. So in your ankle, your tibia to the talus ankle bone, that's the ligament. And when you have an injury like this, those are things that we test. Other things that can be injured are tendons or muscles, and a tendon, by definition, just attaches a muscle to a bone. And there's plenty of tendons that traverse the ankle, the leg, the arm, the shoulder. And when you come to extremity office, or orthopedic or vascular doctor, we're trying to figure that out. Is it a vein injury? Is this a muscular injury? And, Dr. Garrison mentioned an ultrasound. Other things we can do, we get an x-ray. Is it broken? Is there something, because if you disrupt the bone on top with the vein, then that is going to cause swelling. And one thing that, worries people is, say if you hurt the top of your leg because of what Dr. Garrison mentioned with the veins, your foot might swell. So what happened to my foot? Well, really, the cause is higher up, and the swelling just gets backed up. It's almost like a dam effect that's created, and the swelling happens further down. Same in the arm. You could hurt your arm, and wait, the next day my hand is swollen. That's because there was disruption, further upstream, and a dam effect occurred, and then downstream, suddenly you have this accumulation of swelling, blood, and fluid.
Mm-hmm. All righty, thank you. We have a question for Dr. Atherley. It says, if a person, African-American male, is newly diagnosed with rheumatoid arthritis and has a history of winky back, how you like, they even spelled it correctly, how about that, is prescribed hydroxychloroquine, which is the medication that we're using right now for COVID. What could be some effects of this medication being prescribed, number one, and what some other suggestions for joint pain medications? That's their question. So we got.
It's an excellent question from clearly a medically educated patient. Let me first of all explain for a general audience what Wenky back is. The heart muscle requires electrical stimulus to power it, to stimulate it to function in a synchronized and proper manner, so that all the chambers can work effectively together. This electricity passes from the upper part of the heart down to the lower, nice smooth action. So Wenky back is a disturbance of that. There are many ways in which it can be disturbed. Wenky back is one of the most benign and least severe abnormalities of the conduction system of that electrical impulse as it goes from the top to the bottom. Now, Wenky back is not usually associated with the use of the hydroxychloroquine, which has been mentioned. And I'm sure we all know about the hydroxychloroquine and the story in terms of COVID. Maybe I can expand on that a little bit. But it has been in use. It's a drug that has been in use for many years, for malaria, of course, and for arthritic type problems, lupus, rheumatoid arthritis, etc. What I will say in terms of the side effects that we can see in terms of the heart relate to a different aspect of the heart function and not necessarily to the conduction forwards of the electrical impulses. So when we look at the EKG or the electrocardiogram, and we look at the various waveforms on there, we can measure certain aspects which may be prolonged by the use of hydroxychloroquine and may lead to various very serious consequences, very serious irregular heartbeats and even death. And this came to the fore, although we've known of this for many years, this came to the fore when hydroxychloroquine was being popularized for the treatment of COVID-19. We all know who did that. But in any case, the initial studies of using hydroxychloroquine that affected the heart, the initial concerns came in these patients. And we found that hydroxychloroquine not only was ineffective in treatment of COVID, of established COVID, of severe COVID cases, but perhaps even in the earlier ones, although there are some conflicting results and some newer trials, but the larger trials have suggested harm from the hydroxychloroquine. And the harm that was mentioned for these patients was that it could cause the heart to beat erratically and have certain arrhythmias, ventricular tachycardia and ventricular fibrillation are some of the lethal forms. So these are the things that we worry about. In the setting of rheumatoid arthritis, however, we do not expect to see this. And in the setting of Wenckebach, which is usually a very benign irregularity, which affects the conduction of the electricity from the top to the bottom of the heart, we don't expect to find such significant problems. I would say that I would not necessarily stop the hydroxychloroquine when used for the rheumatoid diseases merely on the basis of Wenckebach. But I would certainly urge that any patient taking that with any known electrocardiographic problem should be properly followed with electrocardiograms and physician visits, of course. And if there is good alternative medication, then that may be suggested. I'd perhaps ask Dr. Lee might want to comment on other ways of treating rheumatoid arthritis that might not have such a deleterious potential effect on the heart. James?
Thank you. Yeah, thank you, Dr. Atherley. So, rheumatoid arthritis, that's an autoimmune form of arthritis that where the body attacks itself, the joints, and almost any joint in the body can be affected. And typically, in my practice as an orthopedist, I will see a rheumatoid patient that might have the effects of chronic rheumatoid arthritis, such as joint wear and tear. Essentially, there's an erosion that occurs at the joint surface. And oftentimes, one of my first questions to these patients are you on an anti-rheumatic agent, that's going to help slow down this process? It doesn't cure it, but oftentimes the anti-rheumatic agents can assist in slowing down this process so, there's not continuous joint erosion. And I can tell you that it's a mixed bag in my practice with some patients that don't want to deal with the side effects of the medication, but as the physician, as a physician, I think it's our duty to at least advise and educate, say, listen, if you don't go on this medication, there's a good chance that you'll develop a lot of complications, and one of them being, joint wear and tear and premature wear and tear of the joints. And, if you look at the textbooks, you'll see people with the crooked fingers. You can have spinal deformities. Extremity joints as well can be affected with rheumatoid arthritis.
Dr. Atherley, question.
Yes.
Question. Would you expect to have any damage to the heart if it's normal size heart with no evidence of any conduction abnormalities if a patient has used hydroxychloroquine?
I'm sorry, if the patient has?
If the patient used hydroxychloroquine with normal size heart, no evidence of any arrhythmia or any conduction abnormalities, because so many people would have used it when the president did tout this as a treatment for rheumatoid.
Yes, first of all, the way in which it was recommended and was being used in the setting of COVID-19 was short-term, and therefore I don't expect long-term consequences merely from its use. In terms of the damage to the heart, there were arrhythmias, which are generally time-related and limited irregularities of the heart, which occurred at about the time that was being given. So again, I don't expect long-term consequences from that, but I would certainly have expected, if there were going to be any side effects shown, that they would be shown during the administration of that drug or shortly thereafter. But I do not expect long-term, especially in those patients who have no evidence of significant heart disease. Now, the question of heart disease and COVID has been brought up from time to time, and it is felt that a lot of those patients who succumbed to these medications or succumbed to COVID as a whole had either pre-existing heart disease or developed heart disease during that, which may have been of a structural nature, may have been irregular heartbeats, or may have been an inflammation which affected the heart. So there are many ways in which the heart was affected by COVID. But specifically with that medication, the hydroxychloroquine, the danger that we felt, the dangers that we saw related to irregular heartbeats, where the heart might suddenly beat erratically and such that the patient would not be able to function adequately, and sudden death was reported in some of these patients. So that's why the FDA removed this from a list of its recommended medications under emergent use, and it is no longer recommended for such circumstances.
Right. All right, thank you. What I'd like to do now is I'd like to just take sort of our halftime break and reintroduce everyone. I'm going to allow everyone to reintroduce themselves because people may have come in and not, they weren't there when we initially introduced ourselves as far as our specialties. I was going to do it, but I want to let each of us do it ourselves. Dr. Atherley, can you start off, please?
Okay. My name is Trevor Atherley. I'm a cardiologist. In general cardiology practice means I treat all diseases of the heart. But my specialty, subspecialty is interventional cardiology, where I'm what's called an invasive and interventional cardiologist. It's not a reflection of my character, it's merely a reflection of what I do. I pass tubes into the body, diagnose problems with the heart, and in fact can pass through these same tubes, little balloons and stents, and try to take care of blockages which may have developed in the arteries. So I am a general cardiologist, and as I mentioned much earlier, one of the joys of practice of cardiology is the teaching of cardiology, where I'm very heavily involved as a member of the teaching faculty at the Newark Beth Israel Medical Center, where we train cardiologists and general medicine residents.
All right, thank you, thank you. Dr. Patrick Anderson.
Yes, again, honored to be here. I'm Patrick Anderson. I'm a board-certified obstetrician gynecologist and also a board-certified gynecologic oncologist. Means I take care of women with cancer of the genital tract, ovarian, uterine, vaginal, cervical cancer, cancer of the vulva, participate actively in the planning of the non-surgical treatment of these patients. Unlike Dr. Atherley, on the teaching faculty at Newark Beth Israel Medical Center, where we train residents and fellows. Honored to be among this illustrious group of gentlemen.
All right, Dr. Lee, James Lee.
Yes, thank you so much for having us and Dr. Bay for having us on this panel. James Lee Jr., board-certified orthopedic surgeon. Means I'm a doctor that deals with injuries of the muscles and bones and joints. Practice primarily in Essex County, New Jersey, clinical faculty at Rutgers University.
All right, Dr. Sprott, please.
Kenny Spratt, board-certified pediatrician, background in general pediatrics and pediatric critical care.
Mm-hmm. And Dr. Fredericks.
Yep. Turn this back on. I'm a bariatric trained surgeon that's now strictly doing medical management of obesity. I practice in Essex County.
All right. And Dr. Daniels, please.
So my name is Dr. Lawrence Daniels. I'm an adult and pediatric neurosurgeon. I practice throughout New Jersey. And I'm the director of pediatric neurosurgery at Jersey Shore University Medical Center.
All righty. Thank you. Dr. Court?
I guess he left the best for last.
Not quite yet. But you are one of the best, let me tell you. Go ahead.
Dr. James Court, internal medicine. No kids, no surgeries, and don't deliver babies.
All right, Doc. Dr. Kevin Clark.
Dr. Kevin Clark, I'm a surgical oncologist. I focus on GI and breast oncology. I work at the Newark Beth Israel with Dr. Anderson and Dr. Atherley and Dr. Aluya and Dr. Court and Dr. Bay.
Dr. Aluya, your mic
well,
is...
I guess I'm the last then, so what does that say? Well, Nelson Aluya, I'm a general internist and a pediatrician trained in both. I work at Beth Israel Medical Center. We're also involved in training students and medical residents as well. And assistant professor at the New Jersey Medical School at Rutgers University. And I often call myself a medical advocate. Thank you.
All righty, excellent. Dr. Jordan Garrison.
Hi, Jordan Garrison. I am a board certified general surgeon, bariatric or obesity surgeon, as well as vascular surgeon. I have offices in Hackensack, New Jersey and Florham Park. I'm on staff at Christ Hospital. My primary focus over the last several years has been focusing on chronic venous diseases, including ulcerations, lymphedema, and swelling of the extremities.
All right, and I'm Dr. Omar Bay. I'm a pulmonary critical care physician with a specialty in nutrition. I'm director of nutritional support at Beth Israel Medical Center. Okay, just let me say that, I'm going to say it again, every second Saturday of the month at 1 o'clock, we will be on Zoom. And all you have to do is go to OBHealthy, OBHealthy.com, scroll to the bottom of the page, hit Zoom webinar, follow the instructions, and here we are. You will see all of the physicians here ready to answer your medical questions. Just to let you know, this is very, very important. Don't change any aspect of your medical care until you consult your physician. And I'll say it again over and over again. There are medications, there are different things that we as physicians can do and what we'll say, but don't change anything, because what may be good for you in your medical care may not be good for me. I may have an allergy to a medication or something like that. Only your doctor knows exactly what you should be taking as far as medications, and then you need that appropriate follow-up, okay? One thing I'd like to say, say thank you to OBHealthy for allowing us to use their platform to bring this to you. OBHealthy is a weight loss and health and nutrition website, and boy, they allowed us to use their platform. I'm so happy they're letting us bring this this forum to you. Okay, I think that's it right now. Let me get to a few more questions. There's one question that's here, and it states that, hold on here, there's so many coming in. Okay, here's one. As a follow, hold on, no, I have arthritis, back pain in my lower back. Recently, I started using the product Voltaren on my lower back, a little at a time. The package states that it's for hands, wrists, elbows, etc., but not for the back. The active ingredient is NSAID, which is like Motrin and things like that. Since one of my kidneys was damaged by an aortic dissection, would the light use of this product pose danger to my kidneys or back nerves? Who would like to chime in on this one? I know a lot of us use NSAIDs. A lot of us understand that. I know in orthopedics it's used a lot. Internal medicine, we use it a lot. So you want to start it off? Who would like to start it off? Dr.
Well, yes, I could take it. It's funny. There's a little story with the Voltaren. Voltaren, as a matter of fact, was $600 per tube until recently when it went generic. And the generic component is diclofenac, which is an NSAID. It comes in tablet forms, but then they were smart enough to put it in the form of a cream. Yes, you can rub it. I prescribe that a lot because I see a lot of back pain, and I say put it everywhere except your mouth and your eyes, and any of the other orifices. It works, but then with precaution, we often keep an eye on those with other chronic medical issues, especially people with chronic kidney disease. Again, what's the absorption rate? Does it get absorbed into the system? Yes. Some studies have shown between 25 to 30% or even less, because everybody's rate at which they absorb things through the skin varies, based on your perfusion, based on structure or quality or character of your skin. But then at the same time, if you must use it, keep a close eye on the kidney function, do routine kidney tests, and have your doctor follow it up effectively. We may begin to see a lot more of issues and affectation of the kidneys now, because the cost that has, was $600 is actually over the counter now. And you can buy it for, I can't remember how much, but you can just buy it without a prescription now. So, and a lot more people would use it. And then if more people use it, then there's a risk of abuse. So, but irrespective of what you use or take, I always tell people this. And that's why everybody, and I say this, everybody must have a primary care physician, irrespective of who you are, your cardiologist, neurosurgeon, you must have a primary care physician, because that's the only person who will sit with you, knows you well better than anybody else, and reconcile your medications. Because when you see multiple doctors, each one will prescribe what they think is good for you, but they may not really sit down and know what the cardiologist is prescribing, the kidney doctor is prescribing, the lung doctor is prescribing. But one person who will be able to do that is a primary care physician. And he or she will be the one who will sit and review your labs, and then look to see what are the affectations of everything else you're taking, and what are you developing side effects or anything else. And you should be comfortable enough to ask your primary care physicians. It should be, a good friend to discuss with. It should be free, free to ask questions.
Okay, Dr. Daniels, thank you very much, Dr. Aluya. Dr. Daniels, and this deals with more stroke, but I know you can handle it, brother. Can you explain the difference between a stroke and a brain bleed? My dad fell, and one doctor stated that he had a stroke, and the other stated that he had a brain bleed.
Okay, so technically speaking, a stroke occurs anytime there's damage to tissue in the central nervous system or even peripheral nervous system. So you could have a bleed that causes damage. We call it a hemorrhagic stroke. Or, and most older patients, you can have damage to a brain because it doesn't get nutrients because a blood vessel is blocked, and that's called an ischemic stroke. Ischemia is the term that we use when a portion of the body doesn't receive blood supply in oxygen and nutrients. So the doctors were both accurate. If your father had a bleed, it could be a bleed from a ruptured blood vessel, which would be a hemorrhagic stroke, or it can be a bleed from a fall that leads to an injury in a certain part of the brain. And remember, the strict definition of a stroke is an injury to a part of the brain or the spinal cord or the peripheral nerves, the central nervous system. So they could kind of be, they were using the terms interchangeably, but they probably both were talking about the same thing.
Okay, thank you. Anybody else want to chime in, or we're going to go to the next question?
Well, if I may say something quickly, and I think Dr. Garcia would advance this as a matter of fact, because as primary care physicians, the doctors who see patients on the outside, we often see elderly patients, and as you grow older, muscles get weaker, you get a steady gait, and then the risk of fall is there. Now, people do fall. And as we know, as we age, the brain shrinks. As it shrinks away from the covering, which is the skull that covers the brain, that protects the brain. So as it shrinks, all those vessels that connects the skull to the brain begin to shrink as well, and then elongate. So when an individual who's old enough falls, even a minor fall and small head, bruise to the head and all that, then you begin to have those, strands of brain vessels that connect the brain and the skull begin to tear off, and they tear up easier, and that can lead to a bleed. There, bleeds. I don't want to go a little technical, but there's a subarachnoid bleed, there's epidural bleed, and subdural bleeds, and these are technicalities that we need to know. And if you have any of those, discuss with your doctor. Doc, which one did I have? So you know how best to manage it.
And all bleeds don't lead to strokes. So that bleed that he's talking about specifically, the subdural bleed, it doesn't necessarily manifest with a stroke in the brain, depending on how large it gets, because it's not in the substance of the brain, it's just outside of the brain.
And the other thing that's important is these bleeds can occur remote from the occurrence, from the incident, because they can be slow bleed depending on the location and severity of the occurrence.
Right.
And I guess it's also important risk factors. If you're taking a blood thinner for other problems, it puts you at a high risk for having these type of bleeds, even with, minimum trauma, even with a small minor injury.
Right. Excellent. Dr. Garrison.
Yeah, just to, come full circle on this, I have a comment and also an observation about the strokes. There are other types of strokes, and I think Dr. Daniels was saying that is when you don't get nutrients and in particularly oxygen to the brain in whatever area that oxygen isn't delivered is where a stroke is. One of the primary causes of strokes besides ruptured blood vessels or aneurysms is carotid artery disease, where you have plaque, which is formed in the carotid arteries that will break off and go up to the brain, causing a blockage in the small arteries in the brain and therefore giving a stroke. What is the cause of carotid artery disease? The same causes that happen for the other arterial diseases or cardiac disease or heart attacks is an increased intake of fats and cholesterol and a buildup overall in the body. The comment that I wanted to make, what I walk away from this conversation that we're all having is how multifactorial any one disease process is. It's just not one thing. And that how we all as physicians here work in conjunction with one another to take care of these problems. What Dr. Aluya was saying was, it's so important to have a primary care physician who can serve as a quarterback, who can direct you in the various areas in which you need to go to answer these problems, which are multifactorial and require, you know, the brain power that we're exhibiting in this room to take care of in an adequate fashion.
Excellent, excellent. All righty. We're going to go on to another question. This is one, and Dr. Atherley, and boy, oh boy, we're working you out today.
Right, that's right.
This is a follow-up. It says, as a follow-up, and I think he asked an earlier question, my aortic dissection, how you like that one? My aortic dissection occurred 10 years ago and went down toward my kidneys and my legs. My heart is okay, but I noticed that if I lift anything heavy for any length of time, my heart races and my breath becomes short and labored. What's going on, and what should I do? So we're talking about an aortic dissection that happened some time ago, but he's still having symptoms.
All right. Well, there are a few more questions that need to be asked in order to be able to answer that adequately. The aortic dissection, the location of the aortic dissection, and the kind of dissection.
Doc, what is an aortic dissection?
Right, I'll explain. The questioner utilized these terms. So I'm going to explain to the questioner, to the audience, what the terms mean. But a lot depends on the location. Now, the aorta itself is that large blood vessel, a large artery, which leads the blood from the heart to the rest of the body. But then smaller arteries come off the aorta and go to the individual locations of the body. But the aorta is a big one. It's a large artery which extends all the way through. Now, because of its size and importance, a dissection, that is a rupture or a tearing within the walls of this artery, can be a very serious consequence. And total rupture of the vessel, of course, can lead one to bleed so tremendously outside of the aorta that you can bleed to death. So we take aortic dissections very seriously. Whether we approach them medically, that is merely with medication, or with surgery, depends a lot on size and location and kind. But in general, those that occur closer to the heart may be viewed more seriously in what we call the ascending portion of the aorta. They may be viewed more seriously and may require surgery, which may in fact be needed on an urgent basis. We are sometimes able to treat medically, that is only with medication and no surgery, dissections which occur a little further away in the descending aorta. And then it all depends on whether this tear, which extends in the wall and travels down in the aorta, whether or not that involves so-called vital structures like the kidneys, the intestine, etc. So the decisions about merely medicine, and the medicine we use is to control blood pressure, one of the commoner underlying circumstances that can give rise to these dissections. So whether we use just merely medication or surgery is a decision that has to be made based on the specifics of location and kind. Now, I'm not sure from the question that was asked and read whether or not there was surgery, and now we're talking about recovery after surgery, or if it was a location where it was treated with medicine only and no surgery was performed. Omar, did you get the impression from the question as to whether or not there was surgery performed?
I did not get the question. No, they did not say they had. They just stated that 10 years ago, the aortic dissection went down, went toward my kidneys and legs, but my heart was okay.
No, they
didn't state about surgery.
His aortic dissection is being treated medically at this point.
Okay. Okay, if it is being treated medically, then the question is whether or not this disease process has recurred or whether there's something else. Of course, with the dissecting aneurysm, the kind of pain one would get, especially if it goes lower down, might be back pain or abdominal pain, but not as much heart or chest pain if it is not involving the upper area, the ascending aorta. So it is not clear whether or not the symptoms that this patient is providing us with are related at all to the dissecting aneurysm. But I would say that very clearly there's need for a proper evaluation. The evaluation should certainly be involving the heart, to see the function of the heart, to look at the anatomy, the structure, and to see exactly where this aneurysm is, if it still is there, or if it has healed over. Okay, so there is need for a proper evaluation. Then based upon the evaluation, decision can be again made as to what surgery may be needed. But I hasten to add that the rapid heartbeats and the feeling of chest pain may not necessarily be related to that. But once you have been given that diagnosis in the past, the onus is on you and on your physician to come to grips with the truth of the current situation and to do the appropriate evaluations. And there are many things we can do by way of evaluation, some invasively, some non-invasively, some kinds of pictures that can be done, and kinds of x-rays and MRIs, etc., which we probably will not go into in detail at this point. But it is important to arrive at the correct diagnosis as to your status now, to see the relationship, and then to treat it based upon what we find.
Right. Dr. Corey?
Dr. Anthony, can you comment as to what are some of the more common causes of aortic dissection? Because in my practice, I have not seen too many of those. Maybe the initial cause may have some bearing in terms of what symptoms the patient is experiencing now.
The commoner causes that we will see, one of the commoner ones is going to be hypertension, high blood pressure, and generally uncontrolled. And it allows us the opportunity if patients present with dissecting aneurysm of the aorta on the basis of uncontrolled blood pressure. The opportunity is there to control the blood pressure and then to make decisions once we properly control that blood pressure and adequately taking care of it. But there are other diseases which cause weakness of the aorta itself. One of these is Marfan syndrome, for example. There are several other kinds of diseases, connective tissue disorders, abnormalities of the tissue of which the aorta is made, which can give rise to dissection. But the commonest that we will see and treat, the commonest one that we will see is, of course, hypertension or high blood pressure.
All right, excellent.
If I may piggyback on that,
Yes.
just like since we're talking about the aorta right now and the heart and blood pressure, dissection is one, but the one we commonly see in the primary care setting in most cardiology offices, aortic aneurysm. And what's an aneurysm? Aneurysm is just an outpocketing on a tube. I use the word tube because you can have that in a vessel, or you can also have that in the intestine as well. So, but in the aorta, it's called an aneurysm, where there's an outpocketing because of the weakness in the wall of the aorta. Now, it can be up in the chest, in the thoracic area. It could be down in the stomach, in the abdominal area. Now, what are the reasons that can cause that? It could be genetics, just like you said, Dr. Marfan syndrome. There's also homocystinuria, which is another kind of disease that can put you at risk for that as well. But the most important thing also is for those who smoke. Now, in our community, we have to, if you're age 65 or you smoked, or at any point in time, or you're age 65, please ask your primary care physician to get an aortic aneurysm screen for you. It's called the AAA, get it done. It's done by an ultrasound, just like the same thing that they use in checking the baby in the stomach. They just screen to see the sizes and the dimension of the aorta. And if it's bigger at certain level, because we have benchmark or cutoffs, then they may begin to take steps to one, closely monitor it, or put your medications to mitigate any worsening effect. And if it's that bad enough, they require surgery, then they may have to fix it with surgery.
All righty, excellent. I'm reading some of these questions. They're coming in pretty quickly here. All right, this is one. It's been said that that use of anesthesia for long lengths of time has an increased risk of brain damage. Is brain damage from anesthesia something to be concerned about, no matter what type of surgery? All righty, we're getting a lot of neurological here, and you surgeons, I'm sure you come into contact with this with the anesthesiologist. Maybe you can help us out as far as answering some of these questions.
All right, yeah. I mean, I'll take a stab at it from a neurosurgical perspective, because certain type of anesthesia we use for neurosurgical procedures are neuroprotective. So no, there are circumstances where we want to be cautious about giving patients anesthesia, but it's really on a developing brain. They're really younger patients, usually before the year of age, where there's the brain's still maturing. And we understand that, general anesthesias can sometimes affect neuromigration at a developing brain. But those things have only been shown on animal studies. And there's never been a human study that shows a difference in outcome in cognitive ability and one's ability to use their brain or brain function with general anesthesia or not.
Okay.
I take a stab at this, and maybe Kevin can back me up. I think, if I might understand the question, is it truly directly related to anesthetic agents and the neurotoxicity that occurs from anesthetic agents, or it's a result of what occurs as a result of the general physiology of the patient once receive anesthesia. So if I may take this at different aspects. So for example, there are different types of anesthesia, right? So there are general anesthesia where patients are generally put to sleep and paralyzed. And once paralyzed, the rest of the patient's organ system has to be supported. Those organ systems are the respiratory system, hence a ventilator. So patients has to be adequately oxygenated. And similar to what we talk about with strokes and decreased oxygen to the brain, if inadequately oxygenated, you can have brain damage, which depends on the area that's least oxygenated. Other areas that affects oxygenation indirectly depends on blood supply to the brain, and that requires maintenance of the blood pressure throughout the procedure or throughout the length of the anesthesia. Now, factors which can affect blood pressure is, as Kevin and I know, because we've stepped into this often, is hemorrhage, right? So it's important for surgeon and anesthesiologist to communicate. Guys, you have the right types of lines, the right location, you have the adequate fluids. We often, and Kevin will piggyback on this, tell them, listen, we're getting into some trouble here. You need to make sure you can adequately infuse the patient. In obstetrics, one of the things that happens in obstetrics is when they give regional anesthesia, so blocks below the diaphragm, right? And there are two types. There's the epidural and there's the spinal. These modalities often, you see patients, they become hypotensive, meaning the blood pressure drops. And this often is a result of vasodilation or dilation of the blood vessel that's directly related to the anesthetic agents, the various types of anesthetic agents. One way to get around this problem is before they start the procedure, they'll prehydrate these patients. So often if your a loved one is in labor and delivery and they say, yes, can I have my epidural? The anesthesiologist will come in and they'll give 1 liter or 2 liters of IV fluids before they start the procedure.
All right, excellent.
And
Yes. Yeah, Dr. Court, go ahead.
Some time ago, I've had permanent amnesia post-surgery. Can Dr. Daniels comment as to how often he sees this? And you remember, you know what I'm talking about, your visits. Dr. Bay.
Oh, I'm sorry. Say that again, Dr. Court, because
for Dr. Daniels to comment in terms of how often he sees patients who have had surgery, post-surgery, post-anesthesia, they've had like permanent amnesia for certain events or certain visits.
Right. Okay. Thank you, Dr. Daniels.
So from the anesthesia itself, permanent amnesia, I've never witnessed it. Mind you, when we're operating on the brain and we're concerned about amnesia, it's because we're operating near, one of the parts of the brain that's responsible for memory. Typically when we're doing anterior temporal lobectomies for seizures, and you're going, posterior medial and the temporal lobe. Now, we typically use anesthesia because we're operating on a brain that's neuroprotective. And what I mean is there are certain types of anesthesia that could be harmful to the brain under certain circumstances. Like say, for instance, there's certain types of inhalation anesthesia that increases the intracranial pressure, increases the pressure inside the brain. But under normal circumstances, that's usually not a problem. But if someone has something else that's causing increased pressure in their brain, it can be problematic for them. But there's risks.
What I'm referring to is 5 years ago, after surgery, I couldn't remember being visited by Dr. Bay.
Yeah.
So,
but I remember everyone else.
A part of the medication. So you're giving different types of medication. You're giving a type of medication to put you to sleep, a type of medication to suppress your pain, and you're also giving a type of medication to give you anesthesia. So you don't remember certain events while you're still awake. Like when we're waking you up and you're pulling out the tube, you're awake. But some of the medication you're getting is going to take away those memories. Right before you go to sleep, people always say, oh, they tell me to count back and then I forget. Well, you're not completely asleep before you count back, but part of the medication we give you causes amnesia and erases some of those memories. And people respond to that medication differently. Sometimes people have a greater effect and they have less of effect. that's not an indication of brain damage. I want to be clear. I don't want someone to go around thinking that getting general anesthesia every time you get it is going to damage your brain a little bit. There is risk of injuring your brain going through the process of getting general anesthesia for the reasons that Dr. Anderson pointed out. There's risk of getting a stroke anytime you undergo a surgery, because there's issues with managing the blood pressure, and some of the stuff that we give you, it affects the blood pressure tremendously.
Right.
But
you know,
the
the thing
retrograde
is,
amnesia.
oh, go ahead. Finish up, Dr. Daniels.
But the medication causing damage is rare. It's possible. But
amnesia is possible, very common with the medications that they take. One, ketamine is notorious for that. You know, when you use it, local or anyhow, and it causes retrograde amnesia. And it's, you know, it's not damage, but it's just the process of which your brain, you know, excretes those chemicals or the anesthesia, you know, that was used for the procedure. Because everybody, you know, metabolizes these things differently, depending on what your background, liver function is or kidney function is and all that. And that's why, again, you know, when we talked about preparing for surgery, it's important. You sit with your primary doctor, go through this list. What are you on? What do I need to take off? What would make my anesthesia worse or get better? Because sometimes you may find that some individuals, they try to put them to sleep. It's hard to put them to sleep because of the medication they were on before they came on. So these are things that need to be discussed. And then, you know, if there are questions that you can't answer, your primary doctor or your doctor would contact the surgeon who's going to get it done and say, this is what we need to do, and this is what, and that's the reason why often enough, and Dr. Coates will know this, you always get medical clearance. You know, the surgeons will always say, go get medical clearance before we do anything for you. And then if you have a disease, get a cardiologist to clear you as well.
And there's a difference between having a reaction to a medication that might affect your memory and having damage to your brain. Right.
That's true. Dr. Clark, did you have something to say? I didn't know if you wanted to chime in.
I was just gonna say it's designed for you not to remember. Actually, we don't want you to remember sleep. So it's part of the natural process. Just going back to anesthesia. So as Dr. Anderson pointed out, it's what happens with the physiology so much, not so much the medications itself. So when patients are under, depending on whatever procedure we're doing, the anesthesiologist is charged with maintaining as normal as possible physiology to protect all the additional organs. So it's not the medications necessarily itself, it's a whole process.
Right. So yeah, Dr. Garrison, go ahead.
If we are to be advocates for our patients, then it's very important for us to mention this. This is a very important conversation for anybody undergoing surgery, that you are not going to remember certain aspects because of the medications that you're given. So before surgery, there's a process called the informed consent. And your surgeon should sit down with you and talk to you about the risks, the benefits, the potential complications, and alternatives to surgery. In addition to that conversation, they must also make sure that all your pertinent questions are being answered, because you are not going to remember everything that happens prior to having surgery. And a lot of this goes back to when there is a complications, and surgery is fraught with having complications. The patient says, well, I didn't know that this was going to happen. But those types of things are discussed. Dr. Daniels talked about that initially early on, about how we can give you certain things about what's going to happen. We can give you certain things that may occur as complications. You're not going to remember all those things. So it might be important for you when you signing a consent or talking to your doctor to bring a loved one along with you, somebody that you trust, so that they can hear as well as you hear what you can expect in surgery. And then when things happen in the outcome, you can be reminded that, oh, okay, yes, we did talk about these things. I think it's very important, that whole informed consent process.
Right. You know, the thing of it is I know that you've gotten into it a little deeper, but in doing the procedures that I do, a bronchoscopy, a lot of times we use a medication called propofol. And basically, the patients always, when I start the procedure and after the anesthesiologist is given the medication, I do the procedure, and when they wake up, the first thing they say is, well, when are we going to start? and I mean, it's that good, and they truly do not remember anything. So these medications work well. Dr. Court, I still can't tell you why that happened to you, but I'm glad all your memory post that procedure came back.
Omar,
I just like to add, because something I wanted to talk about before with what Jordan just talked about, the informed consent. Whenever there's a procedure that's going to be done, one of the most important elements of that is, number one, the first part he talked about is information, but there is the consent piece. And so before you sign to consent to something, you need to understand all the things that you talked about, why it's being recommended, what are the complications or the risk associated with it, whether or not, what are the risks associated with not doing it, and if there are alternatives to it. And not only is it going to be related to the surgery, the anesthesiologist also is looking for consent. And some of these questions ought to be asked about whether or not there might be issues in terms of the memory, or what are they going to be using. Because very often you go for a bronchoscopy, or you need to have a colonoscopy or something done, you know, your gastroenterologist says, oh, you're going to do this. And they talk about some of the things, but not this issue of when the anesthesiologist, he just comes up and he just shoots you up with the propofol, you know, and yes, you've signed consent to get the anesthesia, but it's all routine. And, you know, they say it's anesthesia is 99% sort of ordinary and routine, and 1% it's crazy. But the issues in terms of damage, as Lawrence talked about, is related to the fact that the brain requires oxygen and nutrition. If it's deprived of that, it's going to get injured. And the way that it gets that is via the bloodstream. And with the blood pressure, it flows down a pressure gradient. So he talked about things like bleeds, or if you have damage to the brain and there's swelling. There's a certain amount of pressure that exists in the brain normally, but if that pressure goes up, and anything that increases that closed confined space, if there's blood and there's enough blood that's there, that's going to increase the pressure within there, and it will diminish the blood supply. And so there are lots of different things that can occur. But as he said, if the anesthesia is done properly, and the anesthesiologist, in addition to the medication that they're providing, is keeping your blood pressure and your oxygenation and the nutrients flowing to your brain, you shouldn't have any permanent brain damage unless the surgery itself might compromise or complicate these issues. And that's something that can be explained as part of the informed consent.
All righty. Just to let you know, we're moving along, and we have a lot of questions that we haven't gotten to. I don't know if we can extend this just a little bit longer so we can get to some of these questions. Number one, and if that's appropriate, that's fine. If not, and docs have to sign off, I understand, but let's see if we can get a few more questions in here. This is one that just came, well, not just came in, it's been here for a while. Can having had pancreatitis before was attributed to gallstones, and gallstones removed several years ago, lead to pancreatic cancer down the road? I am starting to have similar pains that I had before I had the gallstones removed, but already been diagnosed with pancreatitis. The new pains happen when I occasionally drink a hard liquor, which I know is another way that pancreatitis can be promoted. All righty. So basically, can somebody help me out with this? Kevin, I know that you deal with pancreatic CA, but can you help us out, at least get the conversation started?
Sure. Well, the pancreatitis is inflammation of the pancreas. And the two most common causes are listed actually in the question: gallstones and alcohol. Usually, but depending on the history, we can sort out which of the etiologies or the causes it is. So if patients report drinking an excessive amount of alcohol, which precipitates the symptoms, then it's probably most likely alcoholic pancreatitis. In other cases, if it's being precipitated after a meal and the patients have known gallstones, it may be related to gallstone pancreatitis. Now, The treatment for gallstone pancreatitis is to remove the gallbladder. So it's a procedure called a cholecystectomy. Usually after that's done, you don't have ongoing inflammation related to gallstones for the pancreas, unless there are other circumstances, if you have a retained stone or other things related to the anatomy. But usually after you take the gallbladder out, if the cause is from gallstone pancreatitis, that's it. Again, the question also mentioned that it happened after drinking hard alcohol, which is the other cause. So certainly it would not be unusual for them to get a second episode if they're also drinking alcohol. Now, the issue with pancreatic cancer, any sort of inflammation or inflammatory process that's long-term can theoretically lead to cancers. Pancreatitis in and of itself, chronic pancreatitis over time has been shown to be associated. But if you have 1 or 2 episodes of pancreatitis and you've been treated, or especially if you had the gallbladder out, then I'm not sure that that brief period of time can be attributed or is associated with the future development of pancreatic cancer.
Can I just add something to that?
Yeah, Jordan, please.
As we go back to what the etiology of gallstones are, it's a triangle of hypercholesterol, hyperpigment, and bile salts. So in our population of patients, we go back to nutrition, hypercholesterolemia or high cholesterol. Even though the gallbladder can be removed, the process hasn't been altered, which caused the gallstones. So there's approximately a 3% incidence of having crystal formation in the common duct, or the duct that goes from the liver to the pancreas. So if you have that crystal formation and you haven't corrected the hypercholesterolemia, meaning the patient hasn't changed their diet or the lipids or the fats in their diet, you can have recurrent episodes of pancreatitis, even though your gallbladder has been removed, you're not drinking alcohol. So we have to go back. Again, Kevin said, well, is it alcohol? No. Is it cholesterol? Possibly. Is it gallstones? The gallbladder has been removed. There is even incidents of recurrent pancreatitis of people who have stopped drinking because the pancreas has been damaged. So all of those causes have to be checked out, and they have to be eliminated to prevent the pancreatitis.
Mm-hmm. Yeah, yeah. And the association with cancer, is there, with pancreatitis, if patients that have repeated pancreatitis, is there association with cancer?
Yes, it does increase their incidence of pancreatic cancer. The problem with pancreatic cancer is that it's very, very hard to diagnose, and it usually occurs in late stages. So the cancer will go down. We don't know what a specific marker is for pancreatic cancer until it has happened. So there's no real screening for pancreatic cancer. Anecdotally, I had a cousin who just felt something was wrong, went and paid for an MRI herself, and had a cancer in the tail of the pancreas. It was found early, but then that's not the history. The history is it's usually found late after the disease process has gone on.
Right. I have
one of the things people may not really understand the relationship, but both the liver, which makes bile, which is important for the digestion and absorption of fat, and the pancreas, which makes enzymes that help break down the food that we ingest, they enter the gut very close to each other. And so if you have a problem with one, you can have a problem with the other. And you know, this issue of inflammation, you have an organ and you put like the pancreas, itis at the end of it, you call that pancreatitis. So if you have inflammation of the pancreas, since the pancreas is involved in making enzymes that break down food, you can have destruction of the pancreas itself when it's injured and it starts to self-digest itself. And so it can be extremely painful and also cause high fever. And so it's not something that you sort of will not have any symptoms related to it. The cancer itself usually isn't painful. You know, a lot of times when you think about why you might have have cancer or discovery of cancer, if it's not in a location where as the cancer starts to grow, it starts to cause a problem with pain or some other function, it's not diagnosed until late, like the ovary. The ovary is kind of hanging out in the pelvis, and it can develop cancer and grow and grow and grow. And by the time it develops symptoms, it's far gone. The same thing can happen with pancreatitis. So when you think about what may happen, you breast cancer, you get a lump. You can sort of figure the lump. So a lot of cancers aren't discovered until late because they're not recognized until very late. And the pancreas is one of those that's very notorious for it. But pancreatitis is usually very self-evident because people are usually in a lot of pain because it's sort of damaging itself because those enzymes that help to destroy food or break down food are breaking down the pancreas.
Excellent.
Right.
Excellent.
If I may segue into that a little bit quickly.
Okay.
Especially when it comes to in our community with the issue of pancreatic cancer, we've seen a few which we discovered incidentally, and why? Because often enough, like Dr. Kendall said, Sprott said, it depends on where it is. If it's at the tail, it's really difficult to pick up. Now, if it's at the head, a lot of times, you may have signs and symptoms, and it's such an irony. One of the earliest, and it's documented, earliest symptom of pancreatic cancer is actually depression. Yeah, people should look it up. I mean, if you see all of a sudden you're feeling depressed out of the ordinary without, then, begin to take a look at it. Now, other things that bring them to the hospital or to the primary care doctor or to see the doctor is reflux symptoms. They're like, I have this pain. It's right in the middle here. I feel like I have gas. I have, it's like reflux. And often enough, they treat them for acid reflux without any other alarm symptoms. The alarm symptoms are weight loss, excessive vomiting, and then the other one is the pain. That pain they feel that feels like acid reflux is actually a referred pain that goes to the back. So I always tell my patients, and I teach the resident, if you have somebody who has pain that sounds like acid reflux that's reflecting to the back, there's a weight loss, and then plus or minus vomiting, intractable, get an ultrasound. As a matter of fact, one of the cases that went on for quite a while was actually a lymphoma that wrapped around the aorta. And not until we got an ultrasound, we didn't even know it. So it's important. Once you get that symptom, get an ultrasound and get a CAT scan done.
All righty. Let's go on. We're going to hit some of these quickly. This is one a little bit out of my league, so hopefully we can help this person. My 82-year-old mother sees images at night, and hopefully, Dr. Daniels, you can help us out with this. What could be the cause? Her doctor prescribed, and I'm not familiar with this medicine, quintiapine. I'm thinking it says that seems to minimize the occurrence. Do you have any experience with that, Dr. Daniels?
I don't.
That's quite a pain.
Neurologist or one of the primary care doctors who probably can take care of it. But.
Right, I'll take a crack at that. I run a 400-bed nursing home, Sinai, medical center in Newark. So I see a lot of them, and I see them. So as you grow older, your sleep pattern changes. A lot of things change as well. Constipation, all that. Now, there's what they call sundowning in the elderly. When the reversal of sleep pattern. The sleep more. I'm also. Pardon me if I say this. The sleep reversal almost like kids now. They sleep more in the daytime, and then at nighttime, the whole world expect them to sleep again, but they can't. These are neurological, neurohormonal changes that take place in the brain that result in this sundowning. So, and it's not a psychiatric problem when you see what do you call it? Things as compared to when you hear things. When you hear things more of schizophrenia, but when you see things, it's some form of hallucination. There's another term for it. But yes, disturbance in sleep does help. Quiet pain is actually just like the name sounds. It helps the elderly sleep and helps their brain to relax. So that's why often they use it for them.
Right.
Omar,
Okay.
the name of that medicine is Seroquel.
Yes,
Oh,
that's
Seroquel.
correct.
Oh, okay. Thank you. I know Seroquel. I've never seen that. Thank you, Dr. Court. There's another one
That's a
here.
generic.
Yeah, it's the generic. There's another one. I had a lap band surgery in 2009, and an abscess around my intestines in 2017. I have two friends who had lap bands and have been diagnosed with cancer of the stomach. Am I at higher risk for cancer of the stomach due to the lap band?
No.
No. Okay. That's a direct short answer. All right.
No.
All right.
But a
Sounds
lap
like
band
they're
is
guarding their territory,
Do me a
Omar.
favor. Just explain what a lap band is
Yeah.
and why. Go
lap
ahead.
band is a device that you put around the top part of the stomach, and it sort of makes it a little pouch on the top and the rest of the stomach below. And so the food will settle in that pouch and trickle down into the lower part of the stomach. So you control the amount of volume that you can take in, and the lap band needs to be adequately adjusted. Initially, you put that lap band on and you'll get a certain amount of restriction, but it starts to loosen up. So monthly, you have to come until you get to that right spot of when that person's getting an adequate amount of weight loss and they're getting good restriction. So the lap band is very labor intensive, and that's why it's falling out of favor. You'll get some good weight loss, and at the good programs like at NYU, they get excellent results from that band. But a lot of people can't get that same type of result unless it's diligently monitored. And so sometimes the band can be too tight. Sometimes the band may not be adequately tight enough. Hence, it has to come in and consistently be adjusted until you get to that sweet spot. So if a person's having any kind of leakage or something may have happened to the band where it ruptured, that's rare. I don't know what that person had, what condition they had, where they were having stuff going in, but that's something that's rarely happens. I've never seen a cancer result from a lap band. You may have a stomach cancer, but it's not the results of the band itself.
All right. Thank you.
So Omar,
whenever you have
Hold on.
Go ahead, Jordan.
And then Dr. Sprout, go ahead.
Yeah, related to cancer risk, there are some associated benefits related to reduction of some hormonal related cancer risk with some of the bypass surgeries. And so, if you talk about breast and ovarian, those kind of things, there's been some evidence of risk reduction in the development of cancers of those individuals that have had it. However, there has been some, and I don't know how, correct it is or not, there has been some thoughts about a possible increase in colorectal cancer in individuals that have had that surgery. So I think it's something that Dwayne, sir, I can almost guarantee you that some lawyers will be looking into this issue and coming on TV about something. But I think that this whole issue again goes to this informed consent. People need to ask the questions, and then when you ask the question, you get the research, you provide them with the information, and then they can decide on their own whether or not they want to have it done. Because to a certain extent, if the risk associated with it don't outweigh the proposed benefits, it's the patient's decision to make.
Right. Okay. Thank you. Dr. Garrison, did you want to chime in on that, or was that good?
There were a couple of problems with this patient's presentation when she said that she developed an intestinal infection. What happens if the lap band is too tight, that you can get erosion into the esophagus and the upper pouch of the stomach, which can give rise to that infection. Also, it's postulated just by the sheer presence of the lap band, you get micro migration of bacteria, which can give rise to that. If the band is too tight, or if a concomitant hiatal hernia is not fixed when the band is inserted, then you can get an increased incidence of reflux, which does increase the incidence of esophageal cancers. Right. So that question is a yes and a no in that regard.
Right. Okay, thank you, thank you. Here's another question real quick. Dr. Atherley, how long should I wait to have cardiac valve surgery for regurgitation issues? It's kind of a
Regurgitation
big
issues.
question, but yeah,
Right.
regurgitation, it says valve surgery for regurgitation issues, yeah.
All right, regurgitation means leaking backwards of the blood. Essentially, the valves direct the flow of blood. Since the chambers beat at different times, valves open, blood flows forward through them, then those valves close while other valves ahead of them open, so that when that chamber squeezes or empties, then the blood goes forward but does not leak back into the chamber from which it came. Now, the timing of surgery in a general sense is dependent upon the consequences of this leaking of the valves, whichever valve you're talking about. So you can have the common ones we think about are leakage of the aortic valve, that's the last valve before it leaves the heart, the mitral valve, which connects two chambers on the left side, and the tricuspid, which is one on the right side. Pulmonic valve surgery is much rarer, unless it's something we're born with. So the leakage of these valves can give rise to overworking of the heart. When the heart is overworked and not pumping efficiently as it should, then you may have symptoms of fatigue, tiredness, shortness of breath. These are the predominant ways which recognize that there's a symptom related to these. Then the onus is on the physician, often the cardiologist, to document the severity of the leak. This is done simply by examining the patient, as well as more effectively by non-invasive means such as echocardiogram pictures, ultrasound pictures, other kinds of pictures like that, or ultimately cardiac catheterization, which is passing tubes into the heart for full measurement. So in a short, the answer as to when you decide to operate depends on the combination of A, symptoms, the ones I mentioned, or B, objective findings, that is findings of the heart not functioning effectively or the leak being beyond a certain size, enlargement of the appropriate chambers, when we can see some objective signs to tell us, well, this has reached a serious level and may get worse suddenly, then we decide it is time to operate, but not merely on the basis of a leaking valve. Because many times we have leaking valves in patients who have no symptoms related and who may maintain that small leak of the valves for long periods of time.
Okay, and all righty. We're gonna, what time is it? Okay, so we're coming to an end. There is only a few more questions, but there's one I want to, this one says, African Americans do better with thiazide diuretics and calcium channel blockers. Okay, those of us that treat high blood pressure, I don't know, Dr. Atherley, can you start it? And maybe Dr. Court and Dr. Aluya can chime in?
Yes. Well, because of the various causes of high blood pressure or the related abnormalities of the body that we see that may cause the pressure to get worse, increased volume of blood in the blood vessels, increased fluid, or tightening or constriction of the arteries as they leave the heart, especially the peripheral ones, the ones that go distally, then the medications that we use may be aimed at those two mechanisms, relaxing those arteries or diminishing the volume of blood and fluid that is circulating. Thiazide diuretics are especially helpful in African Americans because we tend to have a higher problem with volume overload. In fact, as you know, high blood pressure is rampant among African Americans, where about 40% of adult African Americans may have high blood pressure compared to less than 1/3 of white Americans. So we are concerned about the volume as one of the predominant problems, and hence thiazide diuretics, which is the medication used to get rid of some of the fluid, is obviously very helpful because we have too much fluid on board. There are other kinds of medications that also help us, and there are different circumstances in which we use different medications. Okay, let me let someone else add to that because otherwise it might go on abundantly. But I like the use of diuretics and calcium channel blockers, yes, by relaxing those arteries which are constricted distally. By relaxing those helps the pressure to fall and to improve that concept of hypertension, high blood pressure.
Right, right. Okay. All righty. Well, you know, I think we're going to make that our last question. I mean, this has been awesome and it's just excellent as far as the answers and the questions. I think that the most important thing is that everyone understand that how important your health is. And, you know, we as physicians, I think we have to stand up and we have to step up, especially in the time of COVID, and really try to educate African Americans and people from African descent about their health, because you want to be that person that lives long, but you want to be that person, most importantly, that lives long healthy. So that's our goal. Our goal is to increase your education about health, about your body, about why you should go to the doctor, about what you should ask the doctor, what your medication should be, what the complications of the medications would be, to have your list ready when you go into your physician. Many things that you need to know about your health, about how to improve your health, how to stay healthy. We want to be there for you. So every second Saturday of each month, except next month, August, we will not be here. But in September, we will be back on September 12th at 1 o'clock Eastern time. Just go to OBHealthy, scroll down to the end of the bottom of the page and hit webinar, and you can come up and ask your medical question. Please, in our community, it's important that we let everybody know about this. And, you know, it takes a village, and we expect each and every one of you to be a part of that village, to be a part of that network. So tell people, tell your cousin, tell your brothers, tell your family, tell your, you know, associates, tell anyone that you think may get value from what we do. And I think that as far as that's concerned, we're going to be here for you. Number one, I would like to thank OBHealthy again for allowing us to use their platform. It's just so awesome that the executive team allows us to come on and do what we do on their webinar platform. I talked about the second Saturdays at 1 o'clock. We'll be here. Remember, caring and sharing. Care enough about your body, doing well as far as your health is concerned, and then share that knowledge. You know, do something for someone else. Take an older person to the doctor. You know what I mean? Take a senior citizen who's in a nursing home out to the park. I mean, do something for each other. It's all about sharing and caring. The last thing I want to say is do not change any aspect of your medical care until you see your physician, because it's all about you taking care of the best, you're taking care of yourself the best you can. And the only person that knows your medical condition better than you would be your physician, because that's the person you follow and that's the person you trust. Okay, so until next time, I want to say, you know, hang in there, guys. COVID is out there. Oh, before I leave, listen, let me just chime in about COVID. You see this right here? This is a health shield. This is a shield. If you're someone out there who's on the front line and you have the ability to wear a shield, wear it. Wear it. It works. Listen, face mask, use it. Listen, I don't care what anybody says. This virus is real, okay? You can have a whole lot of people out there talking a lot of stuff. They don't know what they're talking about. I'm a critical care doctor. I have seen so many people of African descent pass away because of this virus. This is no joke. So social distancing, wearing your mask, wear your shield. If you're, you know, a frontline worker, wash your hands, sanitize your hands. I mean, it's real. So if you and going to, you know, if you're out there and about, be careful going home to your seniors. Listen, if you have high blood pressure, if you have diabetes, if you're overweight, if you have heart problems, you have a bullseye on your chest for COVID. So please, all I can say is be careful, take it seriously, be careful, and wear your protection. Social distancing is real, okay? Until next time, I want to thank all of our physicians that came on today. You know, we're going to be here for you. And until next time, I'm just going to say peace and take care of yourself out there. All righty? All right, peace, everyone.
Good night, everyone.
All right, good night. Peace. Take care.
All right.